Yeah, sure. So I grew up in Scranton, Pennsylvania, actually a small town outside of Scranton, Pennsylvania. Although I was born in Pisa, Italy, because my parents were over there in the 50s. They were Americans, but they moved over there in the 50s. And I liked a lot of stuff as a kid. I liked science, but I really liked biology. But my mom was a nurse, and I didn't grow up in a family of doctors. I didn't really know any doctors, so it wasn't like a foregone conclusion. And my mom was a nurse, and she was a nurse in Scranton during the 80s. And that was a time when, unfortunately, many young gay men were coming back to their homes to die. So, of course, well before antiretroviral therapy, not long after AIDS was even described. So, in the mid 80s, this would be. And, I remember she was an oncology nurse. And so, of course, they were the only people who had any experience with what wasn't even called palliative care then, right? I don't even think that they really had a hospice kind of program that was formally called that, but that's essentially the specialty that dealt with people who were dying, usually of cancer. So when these young men came back to their families, the oncology team was tasked with providing their end of life care. And so my mom got involved in that, and I will never forget her telling me with outrage that some of her colleagues and good friends refused to take care of them. And so my mom, who's a really kind of a good Catholic girl, was really a bit of a social justice warrior in her time in a way that she would never characterize it like that. But it made a huge impression on me because number one, of course, I was coming out. I was actually out by that time, and so it was my community as much as anything. And I also just couldn't believe, on a humane and compassion level, that a healthcare provider would refuse to take care of anybody. So she was a really big influence on me, and she's 98 and a half years old, and still I'm trying to get her to stop driving. So she's doing very well. But that's just a little bit of background. And then I kind of didn't really want to go to med school because it seemed too straight-laced. I kind of wanted to be a little bit more of a rebel. But I kind of got sucked into it because back then, people, when you were sort of smart, you kind of went to become a doctor, a lawyer, or engineer. And I certainly wasn't going to be an engineer, and I didn't know any lawyers. I went to med school, and then I saw my first patient living with HIV as a med student, like many people in Philadelphia, actually. And ended up going to Yale New Haven, which had a fantastic HIV care program. There was an entire ward devoted to care of people living with HIV. And I got very involved in that. I was on the mayor's task force for HIV. Took care of a lot of young women actually in New Haven. And in some ways, they were very reminiscent of what was going on with young heterosexual women in Africa. Many of them had been infected by their male partners, their boyfriends. Many of them were infected through drug use. And it was just an amazing time. It was horribly tragic, as you well know, but it was also an inspiring time to be part of a care team. And that's why I went into ID, because, the challenges were both for social justice, for challenging medicine, and for end of life care. An incredible need, of course, for rapid research, which TAG has always championed. So that's how I ended up in ID. And I went to Seattle to do my ID fellowship because, in part, they were such a powerhouse for HIV and sexually transmitted infections that weren't HIV. So ended up there in the 90s and didn't leave for 24 years. I really wanted to do my fellowship research on HIV infection in women, mostly informed by my experience in New Haven. There really wasn't anybody working in that area in Seattle. And so I ended up working with Connie Kellum, who I'm sure you know
Mhm.
well, and Hunter Hansfield, who at that time, Connie was the director of the STD clinic. She was not, other than working in Bob Coombs' lab for a little bit and having done some work on Western blot interpretation, if you remember those.
Yeah.
She was really in the STD world, and that's how I got started. And I really never thought I would like to be doing work in sexually transmitted infections. You know, it didn't really seem that interesting to me. But I started working in the clinic, and it was so fun, and the people were so great, and there was so much behavioral and community health that was completely different than what I had done in med school and residency. So I got involved in that. I liked the epidemiology of it. I loved taking care of patients and talking about sexual health. I loved the link to reproductive health for women because it was around the time that people were describing the role of chlamydia in particular in creating problems for women like infertility, chronic pain, tubal pregnancies. So that was a very exciting time. And that was how I worked my way into getting interested in vaginal infections. And in particular, some work on human papillomavirus, which I will talk about. And it wasn't just me, of course. It was part of the ethos that King Holmes, in particular, and others had emphasized. And Seattle and has been and remains, I think, an incredibly fertile place for people to pursue overlapping interests. So nobody ever told me, you know, you're supposed to be studying this. You shouldn't be studying that. Or you're supposed to be with this person. Why are you even talking to that person? And that does happen in some of these places. So there was a real appreciation for the fact that, you know, that it was people who were affected. It's not just the organism that we need to be focused on. I think that people who did sexual health, which we didn't even call it then, but also people who were in HIV who were forced to confront the fact that this virus was sexually transmitted, and we can talk about that. That's a whole other interesting area. You know, they were among the first people to sort of see this as a person-centered endeavor, because it's not just about looking at labs and figuring out what to do with somebody's medications. You have to engage with the patient and provide a much more holistic interpretation and management plan. When I got to Seattle, because I was working in STD, and I was working on the chlamydia stuff, I also decided to pursue this other question that I got interested in because of a friend's experience. And like many things, if you get curious about something, you can start trying to figure it out, and it becomes a little bit of a passion. And then this became bigger than that. So I had a friend who was a young woman, probably around 32 or so. She had never had sex with a man. She'd only been sexually active with women, and had stopped getting pap smears because the message was, of course, that, you know, if you hadn't had sex with men, you didn't really need pap smears. You certainly weren't going to get cervical cancer. We knew that HPV, of course, was the main culprit, if not the only culprit. And she had some symptoms and ended up getting a diagnosis of invasive cervical cancer. Luckily, it was early enough that it could get treated. But, you know, she's asked me as the new STD person in our community of friends, you know, how I don't understand this. Like, what happened? There's no information on this. Nobody ever told me that. And actually, there was absolutely no information. And there was good data to say that physicians were telling women who were sexually active with women only that they didn't even need pap smears. So, with support from King and several other people, including Warakowski, I did a small study of about a little under 200 women who were reporting sex with other women, some with other men too, or some with men as well. And we looked for HPV, oncogenic or cancer causing HPV, and wart causing HPV, all those types, as well as asked them about their history with pap smear screening. And lo and behold, we found out that whether or not they had had a history of sex with men, they had just as much cancer causing HPV, either in the genital tract or by serology, so by antibodies, as the woman who had a history of sex with men. And that became interesting because we also asked them about behaviors, sexual behaviors, and we clearly showed that there was an association with penetrative sexual behaviors, which people really weren't thinking about sexual behaviors very creatively at that time. I mean, it was like, as I like to say, if there wasn't a penis in the room, nobody was having sex. And even when there was, they were having sex a very certain way, that could be visualized by the researchers. So it was kind of fascinating, and it ended up informing guidelines from the American College of OBGYN to the CDC to Kaiser Permanente to start screening all women, regardless of their sexual history, for cervical cancer. And it also opened up issues about why some women were really uncomfortable having pelvic examination, which is, fairly invasive and not particularly fun. So I felt great about that because, I got to really force, and I mean that in a kind, gentle way, but I had to really, tell people, people are doing things that you don't know about. And it's not just people having sex in ways that you don't know about, but people transmitting infections. And so you've got to ask people what they're doing, and you've got to really talk to people in a way that opens up the possibility that they're going to get the care that they need. So I was very proud of that, and it just I still hope to this day that there are some women that did not have cervical cancer because of getting screened, I hope. And then your other question about vaccine hesitancy, yes, because when the HPV vaccine came out, the I wouldn't term it hesitancy, and I'm not sure we had really coined that term at the time. With the HPV vaccine, there was so much, I would say, effort to link it to sex and unsafe sex, and this whole concept that giving it to kids early before they started becoming sexually active was going to turn them into sex maniacs, right? Because it was going to make them feel invulnerable, which is insane. So it was more related, I think, to a distaste for the sexual health aspects of a vaccine that was a vaccine that was aimed to prevent getting an STD that just happened to cause cancer. I think they should have really, I wish in retrospect it had been more marketed as a cancer vaccine, but everybody ended up putting it in that bucket. So I would say it was not a global vaccine hesitancy writ large, the way that we're seeing right now. It was a little bit more focused on what that particular scenario meant. But we've always had vaccine denialists and anti-vaccine activists for sure. They've been present for a long time, as long as vaccines has been around. Actually, I think I loved the work that we did on the vaginal microbiome because that was that was a time when the microbiome work is exploding. For people who don't know what that is, that's looking at the community of bacteria that live in your body. The gut is your GI tract is a big focus right now, and manipulating that microbiome in your gut is a huge therapeutic effort right now because we think it's related to a lot of things like your body inflammation. It's related to whether you can absorb drugs. It's related to how you handle chemotherapy. And for women, the vaginal microbiome is very related to whether you have healthy babies who don't have infection. It also protects you against HIV and acquisition of other STIs when you have a healthy vaginal microbiome. So kind of getting into that field and merging, and that's really how I got back into HIV. So here I am doing all my STI stuff. I never really let HIV go. I had a clinic I was a HIV care provider for 24 years while I was in Seattle, so I never really got out. But the vaginal infection work got me interested in things that protect women from infection, as well as the anal rectal immunology that protect or are make men in particular and women more vulnerable to infection. So I ended up through that various kind of route getting involved with biomedical prevention of HIV because you may recall before we were talking about oral PrEP, we were thinking about vaginal and rectal administration of gels, douches, spermicides, all those things. So it was a time when people who understood what was going on in the genital tract at the immunologic level or at the microbiome level kind of needed to be at the table to talk about what those interventions looked like. So it was great because I could bring my experience with the the microbiome stuff to my experience with antiretrovirals, and that's how I ended up running the voice study, which is probably one of my proudest accomplishments. And that was a big study in sub-Saharan Africa that enrolled over 5,000 women and assigned them to either vaginal or pill prep or placebo. And um, the best part of that study was working with the community, because it was, I'm sure you know this, but the study didn't show any efficacy. And the reason it didn't show efficacy is because the participants were really not taking the study products, even though they told us they were. So to me, this was a perfect example. I mean, I wasn't happy when the results came out. It was devastating, but it was a fantastic example of how we think we know what people want as physicians and often as investigators. And we design studies that are very well intentioned and beautifully statistically robust. But if it is not resonating with the people who need the intervention, it is not going to work. And that sounds so obvious now. But it was probably one of the most profound demonstrations of that, in science. And I think for me, it brought into a collision the behavioral health and biomedical people, and it was great because we had to go back and talk to the women about why they lied. What did they really want out of the study? And we now know we have to be very cautious and use biologic measurements, and we have to really think carefully about how we design interventions. It was incredibly exciting. It it The people that I started to work with included Monica Bertagnolli, who had been the National Cancer Institute director and then became the NIH director. They were just very good, and really supportive. I can't say enough good things about the people who work in NIAID. The division directors, many of whom I know you know from your time there, they've been there a long time, were terrific, and they were just fantastic people. And the budget was healthy, and it was a very incredible opportunity to be able to sort of look at this and say, this has worked great for many years under Dr. Fauci. Where does it need to go next, and what needs to be different? Recognizing just a string of extraordinary successes that had come out of that institute. I mean, I can't even begin to list them. I have many slides, including in the allergy field, right? All the stuff about giving kids peanut butter early so that they would avoid anaphylaxis later to peanuts. That was done out of NIAID. And of course, the storied Division of AIDS, which you know well and has been involved in everything. So the thing I think that I was really interested in talking about and moving forward was, again, this more holistic view of people. And so as opposed to like, yeah, there are pathogen people, right? If you're an HIV person in the lab, you're an HIV person in the lab. If you are a gonorrhea person, then you're working on a vaccine, that's who you are. But when you take the total, you really have to look at what affects people as a whole. And this interaction between the immune system, the pathogen, and the environment that people live in, including their sociocultural environment. I think there was an opportunity there, and it was outlined in a really nice strategic plan that we finished in January, but obviously haven't ever had the opportunity to get out, but someday I might. It really talked about the fact that these buckets of funding, these buckets of this, that, and the other thing kind of need to be thought of a little bit more synergistically, going back to this syndemic approach. I mean, you've got neglected tropical diseases, you've got arboviral diseases, you've got malaria and TB that are killing more people, including people living with HIV in sub-Saharan Africa. So it just made a lot more sense to me to start thinking that way. I'm not sure what the outcome would have been ultimately. I'd like to think that there might have been more work across the divisions and more synergy, because there's a lot of partitions. There's a lot of silos, I would say. When you have a lot of money and you get a lot of money, you can just continue to do your work and do what you want to do. So I think that could have been tightened up a little bit. Um, I think the other thing that I really wanted to make sure we kept a focus on was implementation science around HIV without sacrificing the continued basic science discovery work, because I still feel that we have come really far in the cure and vaccine space, particularly the vaccine space. And trying to explain to somebody why we don't have an HIV vaccine after 40 years, but the last 5 years have been amazing. I was very much looking forward to that, because I really think in the next 5 years, we're going to have some significant progress in that field. If we don't take our foot off the gas. And unfortunately, as you probably know, the consortia for HIV vaccine discoveries is probably not going to be refunded, which is, to me, one of the most tragic aspects of what we're seeing now, because those groups are spectacular. We've learned a ton from their work, and people are still getting infected. We're still seeing 31,000 new infections in the U.S. a year. Lenacapavir, or whatever your next new miracle drug is, whether it's the monthly pill or an even more infrequent injection, is an incredible tool. Lenacapavir is magical, really, that you could have a study of and show zero infections in so many women in particular, and equal efficacy in cisgender men and trans women, and drug users. Now we know, injection drug users. The thing about lenacapavir, or anything that requires that level of infrastructure, is that you have to have healthcare workers, you have to have a place to give the injections, you have to have people who want to come and give the injections, you have to have a system to do this. And if anything, the last couple of years have shown us, it's how fragile these infrastructures are. Look at Ukraine, right? Ukraine had a very big, they're still getting PrEP to people in Ukraine, oral PrEP. Imagine having a system built on a more demanding administration schedule and infrastructure. That could be quite a lot more challenged in a setting where you have war being the thing that's ravaging infrastructure. You can have policy and politics that ravage infrastructure, as we have seen, right? So outreach for trans people who really need some of these biomedical interventions, horribly impeded by the politics, of course, of the last several months. So all that to say that I think it's fantastic, but we can't rest until we have a vaccine. There are just too many variables, including resistance. We don't know that much about lenacapavir resistance. It does not seem to be an issue, but we don't know that much about it, and we don't know that yet. And so I think, and then finally, not everybody wants a shot. There are still some people who I think will want to use other methods, on-demand methods, whether it's for anal sex or vaginal sex, or they'll want to use a pill. And so I think we need to keep pushing, and we really need to keep pushing to prevent early acquisition, perinatal transmission. Because that's another area. I think lenacapavir is great for that, but again, you gotta get a system where you're comfortable administering it. So I am extremely excited about it. I couldn't be more excited, but I think to not pursue the vaccine angle is really going to be a bad idea, and really just selling ourselves short in the future.
And same with cure, right?
Absolutely, absolutely. I think, again, because if we can't find a cure, we're still going to leave a generation of people behind, right? Even if we had a vaccine that you could implement as a very early vaccine, you're still going to have, and even if you scale up PrEP, and again, how threatened is that with what's happened to PEPFAR? The other thing I try to tell people about PrEP is that these really beautiful trajectories of what will happen if we roll lenacapavir out, which look great, you're going to reduce infections. They depend on keeping people who are infected virally suppressed.
Yeah.
They assume that you're going to keep giving people who have HIV or living with HIV drugs to keep them not just healthy, but also non-infectious.
Mhm.
And so when you start closing clinics and making access to antiretroviral therapy, which is what we're seeing across the globe, that it's just a recipe for disaster. So this is a situation where if you had a vaccine, at least you would have some backup. No, I guess I would like people to know, particularly the people that have worked with you, for you in your studies and everything you've done. They need to know that their actions could not be more important, have not been more important. We would not be here without what they've done. And I say that because I feel like so much of the vibe in the last several months has been to devalue people, quote unquote, like us. Whether we're gay, whether we have HIV, whether we're working in this space, whether we're trans, whatever, right? We're all feeling like we're being made to feel like less than first class citizens. So what I think we on the front lines experienced as this became apparent was just, of course, horror, but also incredible defiance. It's like, you are not going to take us down and make us feel humiliated because we're working on things and populations and people that we really care about and we think are really important. So I would say the first few months were mostly stressful because we saw this getting worse and worse, and we kept fighting back. And I would say, as you can tell, that we had limited success. We had some success, but things continued to just get worse. So, it was great to see resistance, but like the Bethesda Declaration for sure. But it's just a reminder that you can't stop resisting because there are always going to want to be people who are going to make you disappear, right? I mean, that's what that feeling was. It's like if we don't call them this, we don't call them by their names,
Mhm.
or who they are, then they'll conveniently go away. And that reminds me so much of the work that TAG is known for and obviously became famous for. It's weird. It's just like deja vu all over again. Right. So I would say the message is don't give up. We will get through this. The pendulum will swing. It's very easy to get demoralized, especially when it feels like there's so much hatred and disdain for the people that we are and the people that we take care of. We have to keep talking together and we have to keep speaking out. We also have to be creative. The NIH has been the principal funder of HIV research globally for a really long time, probably since the inception. The budget for HIV is a third, right? It's still a third of the total NIAID budget. Um, and in some ways, I think that that created a lot of comfort because you knew there was that money there that was congressionally allocated. Now, with the disdain for congressional allocations and people not even following what was kind of legitimized, I should say, we can't assume that's going to continue. So that means we have to work more with foundations. We have to work more with industry. We have to work more with multinational opportunities. So you can't say that all of the prime grants are going to come out of the United States anymore. Um, and I think it's a huge shift for us because we have been incredibly fortunate to have the support we've had from the U.S. government. So I think we can get through it. We can do it. I know already that, for example, this consortium for HIV vaccine discovery and development has had a lot of outreach from people who really, really don't want to see this stop. So, people have money. Like, people have a lot of money. Philanthropists have a lot of money. Tech has tons of money. Like, we just need to make them realize that these are the sorts of things that they should be caring about.